I guess I'm live. Hi, everyone. Not sure if we're connected yet. All right. So, people are starting to join. And I'm waiting for Sally to show up. Hi.
Hi, how are you?
Good. How are you doing?
I'm doing good. It's bright and sunny here today. What's it like where you are?
It's actually sunny today, but it was like pouring this morning, so it was really gross, and it's only like 50 degrees. So we're definitely jealous of your weather over there.
Yeah, I ducked out for a quick bite to eat on the beach.
I can't say I'm not jealous.
Yeah.
So I'm just going to introduce you. Sallie Sarrel, most of you guys know, is a pelvic physical therapist. She specializes in endometriosis and chronic pelvic pain. Sallie used to practice in New York and New Jersey.
I technically do still do.
Is it technically New Jersey, or do you is it just Florida?
Currently I'm only telehealth, but I do own my practice in New York and New Jersey still, and now I'm licensed in Florida as well.
Oh, wow. Okay.
But
So Sallie has endometriosis and has been battling with, she's an endowarrior herself, and she founded the Endometriosis Summit. So we're going to interview Sallie because Sallie always does all the interviewing. So this time we're going to ask her questions. And if you have any questions, reach out or comment below, and then I'll also try to get to some of the ones that were asked in my story earlier this week. So, Sallie, I already know, but you can tell me, what is endometriosis and what is the difference between endometriosis and adenomyosis?
Well, I'm so glad that you asked an adenomyosis question because April is Adenomyosis Awareness Month. And the Atlanta Endometriosis Group, in conjunction with Center for Endometriosis Care, reminded me of that this morning. So shout out to all our people with struggling with adenomyosis, because we're going to have to do a lot of content on that now. But endometriosis is when tissue that is similar to, but not the same as, the lining of the uterus is found all around the body. And we had a very interesting conversation on Clubhouse yesterday with Cosmopolitan Magazine that endometriosis is actually at its very core an inflammatory condition, right? So we are debunking the myth that it's a period condition, or it's based on menstruation, or it's just based on hormones. While hormones play a role, it really is an inflammatory condition that deepens and creates adhesions and creates pain, and wreaks havoc everywhere during your period, in your bowels. You could have bloating, you could have stomach aches, you could have it in your lungs. Certainly it causes pain with sex, which is my favorite thing to talk about with Dr. Ahmed. It causes frozen pelvis, which may lead to a lot of the other conditions we could talk about. Bladder pain, you name it. Endometriosis could be the culprit, but it's not always the culprit. Adenomyosis is a condition that sometimes comes with endometriosis, but not all the time. This morning, I saw someone who had adenomyosis solely on its own. And I see really only 2 or 3 of those cases a year because they do usually come together. And adenomyosis is when endometriosis is lodged in the walls of the uterine lining itself. And if adenomyosis is focal, meaning it's in one spot, or it forms a hard myoma like an adenomyoma, you can excise out the adenomyoma or the focal adenomyosis. However, most of the time, adenomyosis is diffuse in the entire wall of the uterus, and in order to fully treat it, you do have to remove the uterus. And I always state that's a choice. And we have a ton, I love your account because we have a ton of pelvic PTs logging on. And patients will come to you and they'll say, I went to my doctor, I went to an excision specialist, and they said I should have a hysterectomy because I have adenomyosis. And you, as pelvic PTs, need to remind your patients that it is their choice and it is their body. And there's a million other things that you can treat that may make it so that they can cope with the adenomyosis. Are we as physiatrists and pelvic PTs going to get rid of that adenomyosis? No. But could we restore somebody to having a quality of life that makes it so that they can make a decision of what they want to do and how they want to live their life from a place where they're not struggling in pain and suffering? Yes, I think we can do that.
Okay. So I'm going to ask you a personal question. How were you diagnosed with endometriosis?
I was diagnosed with endometriosis. I waited 23 years for a diagnosis, which is one of the reasons why the Endometriosis Summit exists, because we're looking to change access to diagnosis. But I had terrible back pain, and I had horrendous burning on the side of my leg and in my pelvis. And I would just drop fist-sized clots all the time, right? Since I was 14, and bloating and whatever. And I treated it with diet, and I went to this pelvic PT. I went to herbal sweat lodge. I did everything. My whole family's.
Did you, just so because the way I talk to patients, I'm trying to figure out, when did you hear the term endo in your age? Like, how old were you?
Well, I heard it in a very strange way. My mother used to say, you need to stop complaining about your periods, because I had real pain. I had endometriosis. So then I never really, and she didn't mean to, I don't want to diss my poor deceased mother, but she didn't mean it that way. But it's a culture in the world that our mothers teach us to normalize pain. It was her showing me to be tough. It wasn't her minimizing my pain. So unfortunately, that's how I heard the word. So I never returned to the word. I'm going to tell you, I went through all my pelvic health training, and maybe I got 10 minutes on endometriosis. So it wasn't until, and I hate to put it this way, if everybody knows the politics of what goes on, but it really wasn't until Padma Lakshmi walked down the red carpet at the Emmys one year, and she was in the most hideous dress I've ever seen in my life. No offense, Padma. And they said she must have had to wear this because she's pregnant after this long, long battle with endometriosis. And then I went and looked that up. And then I went to my local gynecologist, who did nothing for me. And it just happened to be that my uncle, who at one time was chair of gynecology at Yale, knew the chair of gynecology at Rutgers, who did an exam on me and never spoke to me, but called me one day randomly out of the blue from the parking lot on a cell phone, because no one in her office should hear her making a call to tell someone to go outside of the health system, and told me exactly what to look for, and that I shouldn't waste my time with ablation, that I have to find an excision surgeon. So yes, and I was an old lady already. Already my fertility was gone. I had already ruptured a 7-centimeter endometrioma. No one did anything about it. So it took a very long time.
How old were you when you?
I was 35. I was 34. I might have been 34.
Okay.
Yeah.
But at that time, the genetic relationship to having your mom having endo, it wasn't known.
Well, my mom knew the whole time. I don't want to but she sat in the doctor's office the first time we went to a specialist, and the specialist said, you have, the other thing is I was born very prematurely. So that premature birth, preterm labor is a sign of endometriosis. So he said, you didn't know and my mother said, I had period pain. I never had I couldn't keep food down. I never had back pain. And then she goes, I never had any of the things she complained about. And so we didn't know. And I always say that
I think that's important to know, though, that your mom and you could present with really different symptoms. And, everyone's endo isn't exactly like your mother's, your aunt's, or someone in your family. So
Right. And I love when people say like, my endo is not your endometriosis. Unfortunately, the thing that we all have in common is we're all gaslit, we're all minimized, and it takes us all 8 to 10 years to be diagnosed. But our diseases are very different. My mother never had any fertility issues. I could never have a baby if I tried. So it's very, everybody's disease is different. My stomach issues are worse than most of my patients, and I already had multiple bowel shavings. I've had also multiple other causes of pain. We can talk about that later, but I had horrendous issues with hernias, which really led to a hernia revolution, as we were chatting about. But I never had any of the bladder symptoms, which are so common in people with endometriosis.
yeah, so common. So why did you become a pelvic PT? Because you just became one before your diagnosis.
Right. So I became a pelvic PT because when I was 23 years old, I was an ocean lifeguard and I was hit in the head during a rescue. And actually, you can, now that we do all the social media, you can see that my jaw is always uneven. I know you're a dental family, so you'll spot it right away. And I had horrible, horrendous TMJ that actually I ended up living in Florida to be trained and treated at the Upledger Institute. So I became a pelvic PT because I wanted to work one-on-one with a population doing manual therapy. And that was the group that you could do that with. What most people don't know is that I was so sick by the time I ended physical therapy school that I went to work in pediatrics in schools because I would get home. I loved working with the little kids. I don't want to knock that. But I went home at 3 o'clock and I could either get in bed, go to a doctor, or go somewhere for treatment, because 3 times a week I went to chiropractic, 2 times a week I went to acupuncture. By the way, pelvic PT may pay me to do those things, but certainly pediatrics did not. So I didn't throw myself into pelvic PT until I was really searching for what my pain was. And I went to my first pelvic PT class, they only talked about incontinence. And the take-home message in this whole continuing ed class, that was pelvic 1, was don't allow women to use paper towels to stop them from dribbling in their pants. Don't allow women, so now we don't say that. And no paper towels for dribbling in the pants. We didn't say anything about pain. I don't think we mentioned anything about nerves. I think we must have said Kegels 50 times. Oh, wait, and they were very dilator focused and very Easton focused. So pelvic PT has evolved a lot. I see a lot of them on here. It's so amazing to have such support. But yes, I was a pelvic PT. And the fact that I was a pelvic PT when I was being diagnosed allowed me entrance into places normal patients wouldn't get. So I was invited to
Tell me
AAGL.
some things that you as a endo warrior and as a pelvic PT can only understand that is hard for practitioners and providers like me without endo to try to understand. Like, give me some insight.
Well, one of the things, I think if you don't have endometriosis, you don't understand fatigue. So a patient comes to you and says, I'm tired, like I'm cripplingly tired. And I think a normal person goes, yeah, okay, you're tired. But I don't think someone who has endometriosis, they connect to that, because it's an exhaustion that goes through your cells into your bones. And it limits you. It's not that the endometriosis stops you from achieving academically or in your practice. It's that you physically can't lift yourself to move through the day with those things. And I think that gives me an insight. The other thing is, I mean, the nitty gritty of it is I see the impact of pharma, because I know how as a PT people try to manipulate me through industry. And I also see the coding, right? So pelvic PTs, I am not in network because I don't want to be dictated by a code. I want to be able to work anywhere in the body for as long as I want. But I see how that affects people. And people with endometriosis, just like we started, my endometriosis is not your endometriosis, and it's hard to fit us in a box. It really is. And to look at that from the other side as a medical practitioner is really, really a hard thing. And the other thing is, I mean, I could write 20 textbooks on fascia, and it never occurred to me before I was diagnosed that the reason why my fascia was so screwed up and the reason why my nerves were so screwed up was because there were actual deposits and lesions inside my pelvis warping my body.
Okay. So yeah, I mean, obviously someone without endo and without having that touch all the time, and as a pelvic PT, and I mean, tell everyone what pelvic PT is, like, specifically, because a lot of people don't. I always have to explain it, but you can probably explain it better. What happens in a session?
Well, well, we could actually now talk about what happens in a live session and what happens in a telehealth session, because I do a ton of telehealth work, right? So it's important to realize that pelvic PT is people who specialize in the pelvis, but not just in the pelvis, how the core and the thorax interact with the pelvis, oftentimes how the neck interacts with the pelvis, and everything from the foot, knee, and hip, and how that moves into your pelvis. So it's not like we're there doing meniscal tears and exercises on meniscal tears. Which is in the knee, right? We're there if we're treating your knee, it's because how it relates to your pelvis. So inside the pelvis is a series of muscles called the pelvic floor muscles. And I love the way you describe it. I'm going to make you do it. I'm not going to do it. She thinks I'm not the moderator. I'm not going to make her talk. But they sling from your pubic bone to your coccyx and around your body, and they support your body, and you can have spasms within the pelvic floor, but you also can have problems in the nerves, problems in the fascia, problems in your alignment, problems in the ligament, problems in your abdomen that affect it, problems in your spine, lower spine and thoracic spine, problems in your feet. So pelvic PTs are trained with great manual skills to do everything. So when somebody comes to me and they say, but my pelvic PT didn't do any internal, it doesn't really matter, because there's so many things you can access in the body to calm the pelvic floor and to provide that length to the pelvic floor that has nothing to do with internal physical therapy. However, internal physical therapy is one thing we used. So nowadays we do a lot of telehealth. Are you still doing any telehealth or no?
Mostly just new patient consults.
Okay. So I love a new patient consult on telehealth because I can bring up 700 pictures from the Pelvic Guru directory, and the patients love it. So in a telehealth, instead of me working on you, I teach you how to empower yourself, typically through exercise, but I have done it through teaching manual work. And what I found is it's a very good method for people with endometriosis, because it's not lay there on the table and let someone do something to me. Because people with endometriosis typically have had enough done to them. This is some time, my sessions are anywhere from a half hour to an hour, where you can take that space to do something for yourself, specifically for your pain. So I like the telehealth.
Yeah. So just explain what internal is for people who don't know what internal PT means.
And I don't have any of my stuff pulled up. But I do have, I'll show you what I do have next to me if we ask that question. So internal physical therapy can involve someone inserting I use a finger. I don't tend to use anything else but a finger, but there are people who use sensors and stuff like that. But internal physical therapy evaluates the two layers of the pelvic floor. One is a superficial layer. Those are the muscles that are closest to the outside of the vagina, right? And so those are the muscles that are active right at penetration. And so somebody may examine with gloves on. This is a glove technique. Let's like not forget that. And let's also say if you're underage, there's typically a parent in the room. And let's also say that there's always the option to have somebody in the room. So I don't want anyone to feel traumatized. I've been to Dr. Ahmed's practice, and they provide everything to make a patient feel safe, as do I. So I don't want to, I had a whole Facebook discussion on, safety and pelvic PT and trauma today. So when you evaluate the pelvic floor, you may touch the muscles from the outside. You may touch the labia. You may check for nerves. You may use a Q-tip to see if anybody is responding or recoiling for nerves. And then you may stick, if you're checking the superficial layers of the muscle, you may work with a finger, which is approximately 1 to 2 digits deep, right? I'm not in up to my elbows like the gynecologist is. I don't care about your cervix. I don't care about any of that stuff. I really am going 1 to 2 digits deep. If I'm working the deeper layer of the pelvic floor, which is that sling-like hammock support that we talk about, then I'm going to be going in a little bit deeper, and I'm moving my finger. Now, I do a lot of vaginal internal work. What people don't realize is that you can also have rectal internal work, because all of those muscles that are in the pelvic floor that you can access vaginally, you can also access rectally. In my practice, because I see advanced endometriosis cases, I may not do a lot of rectal therapy because people have rectal endometriosis. And especially if they haven't had an excision, it's possible that I could hit a nodule and think it's a trigger point, and then the person's out for like 2 weeks. I feel that if somebody so if you go home and you're a little sore that day, okay. A little sore the next day, maybe you need 1 Tylenol, 1 Advil, I get it. If you're knocked out 2-3 days, then the therapy was too aggressive. I also do a lot of external therapy. I do a lot of myofascial work and a lot of visceral mobilization. I do a lot of nerve blinding, and I love to work on the thoracic spine, because we know that the nerves to the pelvis begin at T11, T12. And for people that have been really traumatized, it's good to have that access point without being on top of it.
That was an excellent explanation for pelvic PT. So someone was asking how they would tell their family member about what pelvic PT entails, and that was really good and helpful.
Wait, can I was being interviewed for Thrive Global earlier this morning, and I'm plugged into the wall, so I can't show you, but I want to have a conversation about what would you do in a 1.5 bedroom apartment where you're doing telehealth for a year. And now my mother has passed away, so she doesn't sit in the chair next to me, but my father sits in the recliner, like and it's an open floor plan, just on the other side of this camera, watching TV in the recliner while I talk about sticking a digit in the vagina. It's very fun. So the thing is, I have endometriosis, and honestly, it shouldn't be about telling your family member, and it could be embarrassing, or telling your friends. It should be about, this is what I need to get better, and I need your support to do that. And there shouldn't be embarrassing. I'd love to ask you, though, you've done a lot of work in different cultures. Is it difficult for people to talk about having pelvic PT in different cultures?
Oh, sure. I mean, people are so terrified of internal work. They feel like their hymen's going to break. They won't be virgins anymore. I mean, you still hear this. I mean, it's really not super shocking, but there are still a lot of people who feel like internal work will de-virginize them.
Well, I do have to point out, there's tons of work that can be done on the pelvic floor to make you feel better on virgins and on people who haven't had sex, because I have that whole part of my practice that's teens, and oftentimes teens aren't sexually active. And my first 2 or 3 years of work was done in the Orthodox community, where that's also very important. And it's lots to do, right? And
So, I mean, even just getting in the door and meeting a pelvic PT, because a lot of times they'll say, like, do they have to go in the beginning? And I'm like, no, of course they're going to make you feel very comfortable. They're not going to push you to do anything you don't want to do. This is all about you and how what schedule you're on. If you want to move, like, but then I'll have patients who will come and say, I have pain with intercourse. I'm getting married in 1 month. How can you help me? And they're in this crazy rush to get through PT. So it's very different. With the young ones, I see a lot of 17, 18, 19, 20-year-old female teens who are diagnosed with endo and don't want to do dilator work. Most of the time, even after an excision, they're too scared to do anything, but they're just terrified of transvaginal ultrasounds. And they don't want to have sex. They just want to be able to put a tampon in. And so they're just terrified of that. And so we'll talk about different things that they can do. And, sometimes they go years without any internal work. So definitely don't have to do internal work if you're not ready for it.
I have patients that have hit their goals, which again, putting a tampon in is a pretty big one. Putting it and putting a speculum in, if you want to look at the Endometriosis Summit today, but who have hit their goals, and they've been some of the worst cases I've seen, and they've never had internal work, because you are able to progress. Which that's when I like to combine pelvic PT with the physiatry. So what do you do as a pelvic physiatrist?
So what I'm doing is sorry, just putting that charger in. I do a lot of basically medical management / physical management with injections and nerve block treatments to the pelvic floor and to the groin area, using suppositories for people for pain. And we're going to get to these questions because we're starting to add up. But essentially what I'm trying to do is get patients to the right places, because if they don't even know they have endometriosis, or I have to break it to them that they might have endometriosis, where they can go so that they have resources. It was great because when the Endometriosis Summit was coming up, I was like, you're really lucky. You can still sign up for the Endometriosis Summit, which is coming up. And they, people were super excited. We'll have them, because when people don't know what endometriosis is, and I have to be the first time they're hearing it, like I have to say it to them, a lot of times patients don't want to hear it. And so just that conversation is so important. I'll be in with a patient for an hour and a half, and we'll talk about why this could impact them and why they should know about it. Because besides being, debilitated and in bed all day for a couple of weeks or of the month, or they're just in so much pain, they also need to know the repercussions of what can happen from having endo that's untreated. And so a lot of it is the conversation, making sure they're getting the appropriate treatment with an excision specialist, if possible, getting them in with a pelvic physical therapist, and then treating their pain with different suppositories, using creams, medications orally if they're super sensitized from having pain for so long, and then nerve block injections if appropriate.
So, I know you can't say the Endometriosis Summit is coming up, but we have a really extensive YouTube channel. We put all of the Endo Summit lives on the YouTube channel.
Oh, great. Do they have access to that whenever?
That is free. So the Endometriosis Summit from March, not up there, but there is a way for me to get people access. I just have to figure it out. But the YouTubes, we have 2 seasons, 2 13-episode seasons on YouTube. And we should be running an adenomyosis summit that's going to be like very small scale, 1 day on Zoom soon, so people can go to that. And then the other thing is that we're going to do a smaller summer Endo Summit live season that will also be free. And now we have the room on Clubhouse at 1 p.m. on Eastern Standard on Mondays. We're like, that's our new thing. We're going to have you. We're going to work it out. We've only done one Monday, so now we have to, you have to give me a chance to do some planning. But we're going to have you. I saw you follow me.
Yeah. So, Sally, this person asked, does having a uterus removed cure endometriosis once and for all? Some people responded back, but so please answer that.
I see it going on, but I didn't scroll through because it's hard.
Yeah.
So, having a uterus removed does not do anything for endometriosis. It only treats disease that's in the uterus. So even though the ACOG standards of care are far beyond the times for endometriosis, we know that even that bad standard of care states that endometriosis by nature of the disease is outside of the uterus. So there's nothing that a hysterectomy can do that can get rid of endometriosis forever. The reason why many doctors believe that a hysterectomy is curative is because they subscribe to the theory that is old and outdated called Samson theory or retrograde menstruation, which means that menstrual blood is escaping instead of through your vagina and coming out your body. It's going through a hole in the tube and swimming all around the uterus, all around the body where it's implanting. We know that that's not the cause of endometriosis because every person who menstruates has retrograde menstruation, and endometriosis is only 1 in 10. We also know there are reports of people who never menstruated in their entire lives who have endometriosis. We believe that endometriosis is laid down when you're in utero. We could also, I've seen and had some interesting conversations about, is it lymphatic spread? And there may be multi causes, but the issue is if you have a hysterectomy and you think you're stopping your period, so you stop endometriosis, you've not done anything for the disease.
What if you take out your ovaries?
Well, wait, what you are doing if you remove the uterus is treating adenomyosis. Mm-hmm. Now, am I a fan of taking out ovaries? No. Would anyone like to see the hair loss that caused me? And also, I didn't consent to having my ovary taken out. If you take out the ovaries, the theory is that you don't have any hormones stimulating the disease. How about we just take out the disease instead? Because if you excise the disease at its root, then you should be okay with having the little bit of hormones that are stimulated. You know, endometriosis makes its own hormones. So removing the ovaries oftentimes doesn't do anything. And I don't know if we'll get to it. We may have to come back, Dr. Ahmed. But I don't believe the ovaries are always generating the pain everybody thinks that they are. Okay, maybe if you have an endometrioma, but you should realize there's a lot of nerves in the area that you all are saying my ovaries hurt. It's almost never your ovaries. It's almost always the nerves. Anyway, yeah. There were a couple good questions.
What is the, what method of definitive, okay, so what is the definitive diagnosis for endometriosis and adenomyosis?
Endometriosis is a disease that can only be definitively diagnosed by surgical pathology. And so it's a big...
What does that mean? What does that mean for the layperson?
It means somebody has to do surgery on you, take a piece of tissue and send it to a lab where a pathologist reads it, sends it back and says, yes, this is positive for endometriosis.
And what about
with adenomyosis, the only definitive diagnosis is hysterectomy, and you have to do pathology on the whole uterus. Now, for those out there that are watching with infertility only, so and particularly with unexplained infertility, which Dr. Vidali and probably Dr. Liu, because I heard their live last week, they both would say there is no such thing as unexplained infertility or silent endometriosis, because if you listen hard enough, you can find the symptoms. But if you have silent endometriosis or unexplained fertility, there is a test where they check for a protein in your uterus called BCL6. It's the Receptiva test. It's not accurate for the pain diagnoses. And if that protein is present, it could lead people to the concept that you may have endometriosis, and that may be why you're miscarrying or not implanting. The issue becomes that then they say, I want to give Lupron and then induce your IVF cycle, but Lupron doesn't treat the endometriosis or the inflammatory component, and it's probably the inflammatory component that's stopping you from implanting.
I'm going to start asking my questions so that all my questions my patients ask me. So does birth control cure endometriosis?
Birth control does not cure endometriosis. Birth control, if we look at, and Dr. Arrington did this well, Dr. Jeff Arrington has lots on informed consent. You can search and look for that. And I think we have one on the YouTube also, but there's sort of a spectrum of how to treat someone. So you could do nothing over here. You could try some Advil. You could start birth control. You could do Lupron. Or you could do surgery. I think surgery should come before, but whatever. So what birth control may do is it may modulate some of the hormones in the body so that the body is not as triggered. But it's not treating anything. It's just more like it's almost like hormonal Advil. I don't know what else to say. The other thing is you can put people on it so that they stop having a period. And the point of stopping having the period is not that you're not letting blood escape into your body so you're not getting endometriosis. The point of not having a period is because not having a period makes you better able to function because you're not in bed for 4 days a month. But I see it all the time, especially now working with the reproductive and fertility side, is someone goes, they put them on the pill at 15, they never come off of it. They get incredibly dry and get vulvodynia. Then they get married. They can't have sex to get pregnant. Then they finally figure out that they want to, and they come off the pill. And lo and behold, there's the endometriosis that has deepened and inflamed and advanced very badly to that point.
So if a patient was not interested in having children, and was not interested, sounded like they had I get this a lot, and sounds like they had endometriosis or have endometriosis, but they've never been tested, don't want to undergo surgery. What are the risks of endometriosis that you could have in your life? Like, will it kill you?
I don't want to say it's never going to kill you, because you could have long endometriosis and you could get a lung collapse and die. So like, there are instances.
Lung. She said lung, not long. So
lung. Lung.
Yeah. Lungs.
In the thoracic cavity. You could have, we would technically probably say thoracic endometriosis. But I also, I have been, endometriosis.
What about ovarian cancer?
Wait, I'm going. Give me a second. Endometriosis won't likely kill you, but it makes you feel like you're dying, and that's not living. So the other issue is that endometriosis will degrade your egg quality. So even if you don't want to have children, there's a value to not going into premature menopause. Does anyone want to see the hair loss again? The dry skin? You're also at a higher cardiac risk with early menopause. Neurodegenerative diseases like Parkinson's increase with early onset menopause. So there's lots of reasons not to have, you really want your system functioning. And the other thing is like the bloating, the digestive issues. You may want to manage your digestive issues on like the gluten-free, dairy-free diet the rest of your life. And that works for you, but you are having an inflammatory bowel forever. I also have worked a lot with urologists, not just one, who have said if you have significant ureter endometriosis and you don't know it and you don't ever want to have surgery for it, when you get older, it does put you at higher risk for earlier kidney failure, because kidneys fail in a lot of people. Yeah. Because that scar tissue is in there. Endometriosis is going to make its own adhesions, whether you deal with it or not. Does that mean everybody has to have surgery? No, surgery is a choice, but you can't go into it saying, I know I have endometriosis, I don't ever want to have surgery, I'll just do meditation. Because unless you've had it diagnosed, not to knock meditation, unless you've had it diagnosed through surgical pathology, you really can't say that you have endometriosis. So ovarian cancer was the next question. I think like it's a very specific kind of, if you have endometriosis associated with one specific kind of ovarian endometrioma-based cell, which is like something like 1% of people have that, then 0.01% of those people can get ovarian cancer. So the risk is low for ovarian cancer. You're going to get 50 comments. My mother had it and had a I know that's going to happen. So the other issue is I had a long conversation with Dr. Antonio Gargiulo, who he's here on Instagram as well. Ovarian cancer really develops in the tube. And we have not yet begun to research, is there anything about the inflammatory component of endometriosis in a blocked tube that could lead to ovarian cancer?
Okay. I think we have the question about, I had a laparoscopic excision surgery 1 week ago. I did the laparoscopy because BCL6 score was high at 3.4. I'm hoping that the excision removed it all. It was stage 2. Will the BCL6 clear now?
Well, BCL6 is just it's a marker of a specific protein. We actually, if you are to email me, I can get you the guy that developed it, Dr. Bruce Leslie, spoke at we do a fertility conference separate from our pain conference. And so BCL6, the levels don't drop. You don't need them to drop to implant. So it's thought that you have decreased fertility because you have endometriosis, not because you have that level.
Okay. So quickly touching on fertility, why do we need to diagnose endometriosis early for fertility? Let's say you're 28 years old or 22 years old, not thinking about children at all, not in a relationship, maybe not even having intercourse yet, but I'm too young to think about fertility.
We need to diagnose endometriosis early for fertility because every person who wants fertility or who doesn't want fertility should get to make their own choice and not have that choice made by their body, right? So endometriosis can, first of all, we have not discussed that endometriosis causes reflexive pelvic floor spasms, which could make sex very unenjoyable, but very difficult to attain natural pregnancy if sex is painful. Endometriosis degrades your eggs. Endometriosis also increases miscarriage risk through the inflammatory nature of the disease. It increases implantation failure, and it increases pregnancy loss. And so to me, to endure one miscarriage is too many. So even if you're like, I'm never going to want a kid, we also talked about that degrading your ovaries over time and having you go into menopause young is bad for brain health, bad for cardiac health. And the other thing is we're so busy normalizing that we're tired because we're busy, our backs hurt because we're sitting, and that's normal, that I think it's important to diagnose endometriosis before those things get really bad, before we stop being able to digest food. So, we want to diagnose early, and you want to have not 15 surgeries, right? You want to have the right surgery done at the right time once.
Yeah, that's a bunch of really good points right there. The menopause one being specifically because a lot of people think, if I'm in my early 20s, why do I have to have a surgery if I'm only, in pain for 4 days out of the month? Do I even need to look into endometriosis for sure? I mean, I might not have it, and explaining to patients how this is going to affect their entire life. And maybe it's those 4 days that are really bad, but there are quality of life measures that are important.
I've had this conversation actually on air with Dr. Arrington and Dr. Vidali, right? And I know the endometriosis community is like, you need to be diagnosed. And if you're 23 and you're willing to accept those 4 days a month, it's your choice, right? And so the problem with endometriosis is that and you should have what he calls informed consent, that endometriosis is these are the possibilities of things that can happen. The other thing is, if you try to get pregnant at 40, you're going to probably need the surgery beforehand anyway, because you need the boost for your fertility. But the problem becomes when mainstream gynecology and people who aren't excision specialists tell a patient, you don't need to worry about it now.
Yeah. So I see a lot of patients who do IVF and fertility workups who've never been told that they could have endo, even though they tell me about their symptoms of it. A lot of times they're told that I'm in my 40s, so they blame it on my egg quality, but they don't tell me. I mean, is it common that a lot of fertility doctors don't talk about endometriosis with patients?
Yes, actually, there's a wonderful article by Charles Miller that I think there's public access to that he just released on a on really it's sort of like a guide to dealing with endometrioma. And the reason why he put that out, he's an excision specialist that specializes in fertility in Chicago. And the reason why he put that out is because it's time for a fertility specialist to stop thinking I'll just do IVF around the endometrioma, right? So the days of believing that the only reason why endometriosis causes you infertility is because scar tissue blocks the tube or scar tissue, ties to your bowels. The scar tissue is creating an inflammatory response that's causing you to not implant or miscarry. So it is so incredibly common. Also, ASRM, which is the governing body of fertility, they adore the concept that endometriosis is fixable by stopping periods. But the reason why you're sick as a fertility patient is because you can't stop your periods. And they're very much on that Samson boat. It's a very deep conversation, which it's National Infertility Awareness Week is coming up in the end of April. And so we could have a lot of talk about that, but they love to do the IVF. I've looked, my best friend, I said, you totally have endometriosis. And she was like, every doctor just tells me to get pregnant. Also, the fertility people still believe that pregnancy is going to cure endometriosis, and it doesn't. And because they think, oh, stop the period, then you'll be fine. All that happens is then they hand you a baby and you still have the disease, and you got to take care of the baby and take care of the disease.
Yeah. So this person's patiently asked this, I think, twice. So who is best to diagnose pelvic floor dysfunction, PCS, or is that pelvic congestion syndrome, central sensitization, and when is best pre and or post excision?
So I believe, first of all, I believe pre-excision, because you prehab. And I know that there are large Facebook groups that disagree with me that it should be excision first. A person is a whole person from top to bottom, and you should systematically treat everything, and you should knock off the easy things that don't need surgery before you have surgery. That's my belief. But I am lucky enough that everywhere I practice, I have pelvic rehabilitation medicine. And so I have good physiatrists who are skilled. That I can't say that for everyone, because I spent my life going to a very good physiatry practice where my dad worked, and they screwed me up all the time and never did any of the things pelvic rehabilitation medicine did. So, but I can say that I like the physiatrist to do it because that's the resource in my area. I'm a pelvic PT who's very advanced at what I do, and I can usually get people, did you try this person? Did you try that person? Did you do that? And I can organize it that way. And lots of our pelvic PTs that have logged on are good for that. So you have to figure out, sometimes it's your excision surgeon. So if you're in Los Angeles, Dr. Orbuck likes to do all of that herself. If you're in, I know Dr. Vidali has pinch hit because he wants to do all of that. He has to do all of that himself because I'm not there. Dr. DeLumba in Texas, the first appointment is 2 hours because he's going through each one of these things on a checklist. But I want to ask you, I've had so many questions about pelvic congestion. How do you diagnose that, Dr. Ahmed?
So I typically will send patients to interventional radiology to do a venogram and see if anything comes up. But it's kind of complicated because a lot of the patients have to present with, different symptoms. And when they have endo, so many of the symptoms kind of overlap with that fatigue or, pressure or, discomfort when they're laying down or standing up. In terms of the pelvic floor dysfunction, obviously we rely on our pelvic, there are way more pelvic PTs than there are physiatrists out there. So patients have more access to that. But central sensitization, do you feel like neurologists are good with that?
No. I mean, do you want me to be honest? No. I think hesitate. I don't like central sensitization to be used as an excuse for not giving good care. Like, you're centrally sensitized, so you don't need, but I do think oftentimes the gynecologists have a team that'll do that, because a neurologist likely isn't gonna listen. Now, I, for some reason, got involved with a whole bunch of interventional radiologists down here, and was chatting with them because they don't have a lot of pelvic PTs that are knowledgeable down here. They have some, but and one of the things with endometriosis,
I'm actually quite surprised you're saying they even refer, like, interventional radiologists are referring to pelvic PT down there.
No, it was I couldn't stay in my mother's hospital room one night, and so they let me stay in the lounge, and there was like 15 interventional radiologists there, and we basically had an interventional pelvic pain conference while we were in there. Okay, so one of the things that we were discussing is that with endometriosis, the inflammatory nature and the way the disease makes adhesions oftentimes is going to like fool you for thinking that it's pelvic congestion syndrome, because you can't drain your veins against the heaviness of the disease, right? And so, or like, you already have back pain from the endometriosis, do you really need a venogram? And so I think that's something to think about. The other thing is, if you have a lot of ovarian cysts on the left, do you have pelvic congestion syndrome, or do you have that the ovary is heavy and the vein can't drain? What's interesting is Dr. Gargiulo talks about that means the artery doesn't work as well, and the egg quality will not be as good in that ovary. If people, I don't know if it's public, if we have GFAM members on here, but Pelvic Guru, who's at Pelvic Guru 1, who want to learn about pelvic congestion, she did a webinar with Brooke Spencer, Dr. Brooke Spencer, and it's phenomenal. But I also find this, if you have the inguinal hernia, what lies in the inguinal canal right next to the ilioinguinal nerve, there's a vein. So that's its own, we're going to do our own hernia thing, because
we have to do a whole different live for hernias. So
we only have 8 minutes left before we get turned off, and I just can't start with hernia now.
Okay, so I'm going to ask just maybe one more question. Well, one really quick question. How do you find experienced doctors for excision surgery?
I think it's really important to understand what you're looking for in terms of excision surgery. So
I live in Kansas. I can go basically to my one state. What do I do if I can't find an excision surgeon?
If you can't find, so the other thing is, you have to be able to understand that's why we love crowdsourced education like this. So by coming on here, you've advanced your ability to find an excision surgery. So like, it's not like a catalog. I think that it's not like you like, oh, there you go, and I'll just go there. You have to be educated enough to understand the ins and outs of endometriosis. And some people are like, I'm the patient. Why should I had a call from one of your patients last year who was like, this is stupid. Why should I be like this? I just want it fixed. It's not like that in endometriosis. You're going to need to be trained to interview your doctor. And if somebody's like, well, I do some excision and I do some ablation, then that's probably not for you. If there's somebody who can say, I do 300 to 500 cases of excision a year, I don't deliver babies anymore, I have a bowel team, I have a lung team, let's go, then that's different. And the other thing is, you have to reach out in the groups, be it Facebook, Reddit, LinkedIn, Instagram, Clubhouse, and find patients who have had successful excisions and who can produce, many of them can produce, yeah, I know it was excision because I see it on my photographs, And the other thing is, use your resources. So like, if you're in, I think Iowa, we have a hard time finding an excision surgeon. If you're in Iowa, then you're the person who's up at 9 a.m. on with the Endometriosis Summit, writing down every single thing they say. I'm also going to add that you think that traveling is out of your budget, And you should never deny that there are some amazing excision surgeons, both in Mexico and in Romania, that could be very affordable if you have to travel for care. And it's scary to think about doing that, but there are surgeons that day in and day out are doing excision that are affordable. And sometimes traveling means that you can get an in-network surgeon also.
Yeah. Okay, Sallie, how did you change the narrative for endo?
Well, I don't think any of us sat. How did I do it?
What are you doing to change the narrative? I mean, you're doing it already. The endo
Right.
summit.
I don't think any of us sat here and first of all, no one talked about pelvic PT for endometriosis really before I pushed it, and I was lecturing and pushing research in it. So, but I used everything I had to change endometriosis. So I have a medical license. I can use that. I have a voice that needs to be heard, that I am a very good interviewer and presenter. I use that. But somebody else, you know, Lori Johansson is an excellent example. She has art. And so her art reflects her endometriosis journey to reach people. And changing the narrative in endometriosis, first of all, means being properly educated. It means understanding, unfortunately, why the ACOG standard of care matters for the endometriosis patient, and then going from there. So if you're still using retrograde menstruation, if you're walking around calling it a womb disease, these aren't going to, this is the old narrative. But you use what you have. Dr. Ahmed is a doctor. She uses what she has. I use what I have as a pelvic PT and as an advocate. Other people can cook meals and hold benefits that way, educational that way. Other people can't do anything but take a few minutes to listen to an Instagram live, and that's okay.
Yeah, that's really important for people to hear. Also, a lot of people do reach out and ask how they can get involved and what they can do, but they feel
we take all volunteers with the Endometriosis Summit, because you never know who has some skill that could make a difference for everyone. Like it's amazing.
Okay. And then what causes endo? This is our last question. Last and final question, True Blue.
I think we did that in the beginning of the live, but endometriosis for a long time was thought of to be caused by retrograde menstruation. And we now believe that retrograde menstruation is not the single solitary cause or cause of endometriosis at all, because there are people who don't have a uterus and therefore never retrograde into their bellies that have endometriosis. You can remove the uterus and endometriosis can still deepen, and everybody retrogrades and not everybody has endometriosis. 1 in 10 have endometriosis. So many believe that the cause of endometriosis is multifactorial, from stem cells to lymph. And of course, we do believe that to some extent, endometriosis is laid down when you're in utero and then becomes hormonally and inflammatory reactive. But I'm going to say this, the cause of endometriosis truly is unknown.
I think it's a really important point. Anything else you want to say, parting words before we're kicked off?
Thank you for joining us. I fully believe that if endometriosis is going to change, it's going to take the endometriosis community to fight for changes. And it's important to understand that there are multiple causes of pain, from pelvic floor dysfunction to nerve disorders to adenomyosis is a separate cause to hernia. And as long as you believe in yourself, you can find the help that you need.
I totally agree. Thank you so much, Sallie. It's been really lovely talking to you. It's been such a long time since we've talked.
I know, I miss everybody. Soon, probably about 4 weeks soon. I mean, unless you want to talk more like this.
Yeah, we could definitely do another one like this. All right. Thank you, everyone, for joining. Have a great rest of your day.
Don't forget to save it, because when you save it, you can auto caption it.
I know. I don't even really know how to do that. So do I X?
So no. So you when you X, and you can post it to your IGTV, but you can save it, and then as you save it, you go into settings, and there's an advanced setting, and you hit auto caption.
Okay.
But Dr. Vidali couldn't do it. So, you know, life goes on if you can't figure it out.
Okay. All right. Well, it was great talking to you. I'm just waiting for them to shut me off.
Oh, well, that's fine. You know, they didn't shut us off yet. I mean, I also think we've had a lot of discussion this week in changing the narrative around gender-based language. What, you know, what do you like? How do you like to manage that in your practice till they shut us off?
I mean, you know, I've actually had a few trans male patients, and it's really tough because for a lot of them, like they are so embarrassed and they don't know how I'm going to react to it. And we explain to them, like, this is the same thing. We're going to do an exam, whether they are, whether they transitioned or not, exam, you know, the way, and we ask them how they want to be addressed and, how, you know, what is important for them, because it really depends on if they had a previous surgery or if they haven't. I mean, we don't have a ton, but we have seen a few in our practice. I don't know. Have you seen a lot in your practice?
I get a lot because of the work that Endometriosis Summit does. You know, our first year we did an extensive panel with Corey. And Corey is somebody who has endometriosis. He's a trans male, and you could sit, I've heard his story privately, and you could sit and cry. I heard it through his partner's eyes. And I think that is different when you see the person that loves somebody tell the story, and it's like demoralizing that he could go into ERs and be denied care. Or Dr. DeLumbo, when we had that panel the first year, said that certain insurance companies won't allow a gynecologist to treat someone who has fully transitioned because then they're male and not, and that part's really traumatic. Our work this year really has been in the language, because there are plenty of people that don't identify as women. Mm-hmm. And so to go to women's health, to go, and I don't buy it like by putting the X where the E is. I just think like we got to do better than that. I know lots of people buy that. And so like I had a meeting last night with somebody, and we were working on language for a project they're doing. And the concept is you want to honor that this is reproductive justice issue, endometriosis, and the experience of women. But you have to honor that not everybody who has endometriosis is a woman, and you can't demoralize or isolate people anymore because it's hard enough to find care. And then 100%. They're not going to reach out.
100%. All right. Well, Sallie, I think I have to exit and figure out how to do this. But it was great talking to you. And we have to do it again. We'll talk about hernias.
We'll talk about it soon. We could give away the book.
Yes, we could give away the book. We can definitely
our next live, we'll have to give away the book because the price point on the book is not good, but that's a different story. All right.
All right. Have a great day. Enjoy.
Bye.
Bye.